Um, Emily?
Great. So our next presenter is Nikit Kadan. I didn't know if you want to introduce him, Jay, because you'll know more about his PhD than I would.
Okay, Nikit has been our registrar trainee for a long period of time. I think now he's doing a PhD with us on in the recurrent miscarriage population, looking at the use of ultrasound in terms of identifying uterine morphology, and see whether we can compare that with people with normal fertility to pick up any cues in terms of improving the outcome next time. So he started off with diagnosing acquired uterine anomalies, and one of them is the adenomyosis. And surprisingly, I must admit that the prevalence of adenomyosis is so high. But obviously, to begin with, we wanted to make sure that how reproducible are the adenomyosis, based on the MUSA criteria. So, which I'm sure Nikit will enlighten that further. Over to you, Nikit.
Thanks, Prof. Thanks for the kind words and thanks for the intro. Afternoon all, my name is Nikit. I'm one of the Obs and Gynae trainees out of program for research and currently in first year of my PhD. Firstly, I would like to thank Mr. Abdul and Emily for giving me this opportunity to talk about my study. So my thesis is about application of 3D ultrasound to evaluate the relationship between uterine morphology and reproductive outcomes. And as a part of my thesis, we did the study to examine the inter and the intra-observer agreement of ultrasound features of adenomyosis defined by the MUSA criteria. Right. So we all know what adenomyosis is. It is a benign gynae condition which is characterized by presence of endometrial glands and stroma in the myometrium, which could be accompanied by hyperplasia of surrounding myometrium. Now, approximately 30% of women are asymptomatic. However, they could present with symptoms like abnormal uterine bleeding, dysmenorrhea, or infertility. With regards to prevalence, there is a wide variation in prevalence of adenomyosis, depending on the population that is studied, and it also depends on the diagnostic tool and the diagnostic criteria that have been utilized. Now, several studies have documented the prevalence of adenomyosis. It ranges from 5% to 70%. So that's the significant variation. The substantial variability is due to the fact that there is lack of a standardized diagnostic criteria for adenomyosis. Now, one such review, which was done by Epson and colleagues in 2020, where they analyzed the prevalence of adenomyosis on hysterectomy specimens, found that the adenomyosis was prevalent in around 61% of patients, while in another study where the prevalence was calculated on imaging, found the prevalence was around 20%. Now, in fact, some often say that adenomyosis is not a pathology, it's just a condition that exists. Now, historically, adenomyosis was diagnosed using histology of hysterectomy specimens. But transvaginal ultrasound and MRI are commonly used non-invasive diagnostic modalities. In 2015, MUSA, which stands for Morphological Uterus Sonographic Assessment, published a consensus statement proposing a standardized terminology and criteria for ultrasound features of adenomyosis. And this was done to ensure consistency in clinical practice. Following on, a reproducibility study by Rasmussen and colleagues in 2019 reported low to moderate agreement for diagnosing adenomyosis. Moving on, in 2022, the MUSA group redefined the features and classified them as direct and indirect features. To the best of my knowledge, no reproducibility studies have been reported or published on the redefined MUSA criteria. So what is this MUSA criteria? As I've mentioned in my slides earlier, it stands for Morphological Uterus Sonographic Assessment. So basically, it is a classification and reporting system of ultrasound features of adenomyosis. The features could be direct features or indirect features. Now, direct features are more typical of adenomyosis, and these are due to the presence of ectopic endometrium in the myometrium. Indirect features are secondary to the presence of ectopic endometrium in the myometrium. In the absence of direct features, the presence of indirect features is not conclusive of adenomyosis. Now, what are the direct features? Direct features are myometrial cysts, which are rounded oval cystic spaces in the myometrium. They could be of any size. The second direct feature is hyperechoic islands, which are hyperechoic areas scattered throughout the myometrium. They could be of any size. They could be regular. They could be irregular. Thirdly, subendometrial lines or buds, which is invasion of endometrium in the myometrium, which is perpendicular to the uterine cavity. When it comes to indirect features, the first feature is globular uterus, where the uterus is just spherical in shape. Then there is asymmetrical thickening, where the ratio of thickness between the anterior and the posterior myometrium is more than 5 millimeters. Then there is fan-shaped shadowing, which is alternating bands of hyperechoic stripes and hypoechoic stripes. Then there is translesional vascularity, where the vessels cross the adenomyotic lesion. And then you have irregular junctional zone, which could be because of cystic spaces or subendometrial lines or buds. And then there is interruptions in the junctional zone, where a proportion of a junctional zone is not visualized by a 3D or a 2D ultrasound scan. So the aim of my study was to evaluate the inter and the intra-observer agreement of these features, which are outlined in the updated MUSA consensus. So my study was a prospective study which included around 74 women aged between 18 to 45 years of age. Our study included patients who were seen in our dedicated recurrent miscarriage clinic. And also, in addition, we also had healthy fertile women in this cohort. Now, all the women were asymptomatic at the time of recruitment. A written informed valid consent was obtained before recruiting them. All of them had a 2D and a 3D transvaginal ultrasound with a power Doppler, which was done by a single operator. To assess the inter-observer agreement, these 3D volumes were analyzed offline independently by 2 investigators, whereas to assess the intra-observer agreement, single investigator reanalyzed these images 2 months after the initial review. The 3D volumes were evaluated systematically for presence or absence of direct or and indirect features. The diagnosis of adenomyosis was established by the presence of a single direct feature. We also employed a study checklist to ensure a robust data collection. And finally, the reproducibility was calculated by using the Cohen's-Kappa coefficient. So what we found, this slide presents the kappa values here, and the horizontal bars, they represent the confidence, the 95% confidence interval. And it is clear from the slide that the diagnosis of adenomyosis achieved a fair level of inter-observer agreement with kappa of 0.27. Similarly, myometrial cyst and hyperechoic islands also achieved a fair level of inter-observer agreement with kappa of 0.21 and 0.24. In contrast, the subendometrial lines of buds achieved a poor inter-observer agreement with kappa of 0. The inter-observer agreement for indirect features varied from moderate to poor, with globular uterus exhibiting the highest agreement with kappa of 0.54, whereas fan-shaped shadowing achieved a poor inter-observer agreement with kappa values of 0.19. Coming to the intra-observer results, and you can see from the slides that from the slide that the results were pretty much similar. The intra-observer agreement for diagnosis of adenomyosis, in fact, had a poor reproducibility with kappa of 0.13. Coming to the individual direct features, hyperechoic islands and the subendometrial lines and buds achieved a fair level of intra-observer agreement, while myometrial cyst achieved a moderate level of intra-observer agreement with kappa of 0.45. The agreement levels, the intra-observer agreement levels for the indirect features feature ranged from poor to very good, with globular uterus and asymmetrical thickening achieving the highest reproducibility with kappa of 0.64 and 0.8, whereas fan-shaped shadowing achieved a poor level of agreement with 0.18. This slide summarizes the inter and the intra-observer results, and it is quite evident from the slide that the agreement levels were widely varied. Now, as I've mentioned in my slide earlier, that direct features serve as definitive diagnosis or definitive indicators of adenomyosis. The existing literature on intra and the inter-observer variability is relatively limited, and the findings have been inconsistent, which was highlighted by studies done by Neil and colleagues and Anderson and colleagues as well. Now, the variable agreement could be because of multiple factors. Firstly, small myometrial cyst and hyperechoic islands could easily be overlooked. Secondly, they could represent a normal aspect of uterine architecture. Thirdly, the redefined MUSA criteria does not specify the precise precise size threshold for cyst and hyperechoic islands. So addressing these issues could facilitate better management of patients. The agreement levels for the indirect features also was widely varied, which ranged from poor to moderate for inter-observer and poor to very good for intra-observer. And these findings were consistent with other studies done by Rasmussen and colleagues and Duoholm and colleagues as well. Now, the subjective variation could be due to limited consensus regarding the individual indirect features. As always, our study had strengths and few limitations. One of the key strengths was our study was the first published study examining the inter and the intra-observer agreement of the updated MUSA criteria. Our study had a consecutive cohort comprising of women who were referred to a recurrent miscarriage clinic and also a healthy fertile population. Both the observers independently evaluated the images while being blinded to ensure a comprehensive data collection. The ultrasound was performed by a single operator to ensure a high level of consistency. And our study was one of the few studies to utilize both 2D and 3D ultrasound criteria. We had a few limitations as well, and one of the potential limitation was we used offline analysis of volumes as opposed to conducting a real-time analysis. However, 3D offline analysis is comparable to real-time analysis. Another limitation was a small sample size, but we feel that the numbers were sufficient to answer our research question. So I end by concluding that the diagnosis of adenomyosis based on direct features demonstrates suboptimal reproducibility, and hence it is clinically challenging. So our study underscores the importance to undertake further studies to precisely define the diverse ultrasound features which are set forth by the MUSA group, which would enable early diagnosis and improved patient care. Thank you, and I'm open for any questions.
Okay, thank you very much, Nikit, for good work. I think, because of the time, we will probably go directly to the next session. So over to you, Emily, for the afternoon session.
Yeah, I'll just stop sharing my screen.
Yeah, no problem.
Yeah.
Well, the one thing
Thank
I
you.
will say is that the question was actually from Prof. Amar, who is our next speaker. So I don't know whether, Prof,
Okay.
you want, while you're setting up your slides, whether you want to ask your question.
It depends on your time schedule.
Yeah, if you want to make it super quick, then I'll let you.
just quick. Very interesting study. Well done, Nikit. Just 2 points. One is, I think you need to highlight and that's relevant to your findings, the experience of those who reviewed the images. You need to highlight whether, because this can be obviously challenged, maybe are they enough experience or not. Secondly, so the take-home message from this is, it seems that the ultrasound diagnosis remains unreliable for adenomyosis, and hence maybe what about, should we recommend MRI if we suspect it or not?
You're muted, Nikit.
You're muted.
Yeah, so with regards to the investigators, both the investigators had more than a year of experience in scanning.
Okay.
So they knew what to look for in a scan. With regards to your second point, Prof. Amar, yes, ultrasound, definitely. I mean, the MUSA criteria, because it has got low reproducibility, it's not very definitive of adenomyosis. So probably in that case, I'm not sure, probably MRI would be better, but there have been studies which have shown that MRI and a 3D ultrasound scan are comparable.
Okay. Well, thank you so much, Nikit, and for fantastic work, and good luck in the rest of your PhD. So our next speaker, Professor Amar, I'm very